Good evening, everyone. I think we should start. We'll continue our tutorial on this very important topic, smart ventilation in the ICU. And I hope you can still hear me.
Yes, Prof.
Yes,
Yes,
Professor.
Prof.
we can hear you.
Okay, thank you. All right, so we started last week on smart ventilation. And we did say that mechanical ventilation is one of the commonest indication for admission in the ICU. And a study that we did some years ago at the University of Benin Teaching Hospital, we found out that 34% of all patients admitted to the ICU were mechanically ventilated. And we also found out that patients requiring mechanical ventilation had about 4 times chance of dying when compared to non-ventilated patients. So mechanical ventilation is very important, and we did say that smart ventilation is a way of using a mechanical ventilator in a smart manner, just like our smartphone. You know, as important as mechanical ventilator is in saving lives, but if it's not used smartly, it can actually be a dead boss. And I did tell us how there are a lot of instances of autogenic ventilator induced lung injuries in the ICU. We had one who had developed bilateral tension pneumothorax because of poor ventilation management. So mechanical ventilation is important, and we did say that smart ventilation is geared towards goal-directed ventilation. All right, that implies that we need to understand the indication for ventilatory support, the workings of the ventilator. And we did say last week also that we have different ventilators from different manufacturers, and they have different settings, different modes. So you need to familiarize yourself with the ventilator that is available in your unit. But it's also very important for you to know the modes that are available in case you practice elsewhere. And more importantly, we need to understand the ventilator-patient interaction, because this is important. And the ultimate of good directed ventilation is what you hope to achieve when you're putting a patient on ventilator. And more importantly, the day you initiate mechanical ventilation, you should initiate weaning the patient off ventilator. Otherwise, you have a patient who is mechanically ventilator dependent, and sometimes you may need to discharge the patient with the ventilator. So this is all the ideas of smart ventilation. And we did say that SMART is an acronym or a mnemonic. The first S is setting. All right, you need to know the setting. And the setting depends on the patient, depends on the pathology, and depends on the goal that you want to achieve. And we looked at different settings in the ventilator. All right, and we did also say that the second one you need to consider, what is the mode? And we said that the mode of ventilation determines how the mechanical ventilator supports the patient's breathing. All right, we mentioned earlier on that mechanical ventilation could either be a way of taking over the patient's breathing entirely, or you support the patient's breathing. So the mode that you're going to set on the ventilator will determine how this ventilatory support is given to the patient. All right, and we did say that each mode of ventilation can be distinguished by the triggering mechanisms, whether pressure or flow trigger. All right, and how the patient sustains the breath. That talks about the pressure limit, and how the patient terminates the breath. That is circling. And cycling talks about how the patient moves from inspiration to expiration. So we did say that the best mode that you should adopt for a patient is that which provides the maximum therapeutic benefit with the fewest side effects. All right, we looked at different modes last week. We're not going to go into that because of time. And I hope that we had time to go back to our units and look at the different ventilators that we have and the different modes. How many of you have seen any of the modes I mentioned in your ventilator after the lecture last week? Did you see any of the modes that you were not used to, but that after mentioning in this lecture, you were able to see some of them in your ventilator? Anybody? You can quickly unmute and answer. It's a tutorial. Did you come across any of these new modes I introduced last week in your ventilator? Anyone? Advasta Killerway, were you here last week?
No, Prof, I'm joining today.
Oh, okay. Agogo Isaac, were you there?
Yes, Prof. I didn't attend, but I listened to the recorded lecture. Yes, Prof. I saw though I didn't use it. I saw the APRV and other ventilatory method modes, but
So
I
you
really
saw
didn't use it.
different modes after the lecture?
Yeah, I saw a few more. Yes, Prof.
Did you try to use them?
Yes, the APR. No, Prof. No, Prof.
Well, you
you
were not confident. Felix Amani,
No, I
did you
wasn't
see?
confident.
Okay, Felix Amani wrote in the chat, yes, we did. Okay, great. That is the idea, all right? Don't be afraid. Just go over the lectures again, look at the different modes that are present that you're not used to, and try to use them. You just know the indications, and it's beautiful. You can save you a lot of houses, especially in patients who are finding it difficult to ventilate. Other modes of ventilation may just help this patient. All right, I'm happy that we saw some of this. Okay, so today we're going to be looking at the third letter in our acronym or mnemonics, and that is adjuvants. All right, the adjuvants in your smart ventilation. And what does this mean? Adjuvants are different modalities that can be added to your settings, all right, to improve your target ventilatory goals. Let me repeat it. All right, sometimes when you initiate mechanical ventilation in your patient and you are not achieving your set objectives by placing the patient on ventilator, these adjuvants come to help. All right, they are like extras, so to say, that can be used to improve your outcome, either in terms of ventilation or in terms of oxygenation. All right, the Canesa from Canesa said, please, there all, may you please identify yourselves with your proper name, please. All right, this is for attendance sake, okay? So these are adjuvants. There are different adjuvants that can be deployed, all right, to aid our goals in achieving our goals. And I like mnemonics. The mnemonics for adjuvant is called Philippe. All right, Philippe. All right, it's a mnemonics I developed, and the first P there is PEEP. All right, we're all familiar with PEEP, but let me say that PEEP is an adjuvant of mechanical ventilator or ventilation and not a mode on itself. All right, so it's an adjuvant, and I need us to understand that. So PEEP is positive end expiratory pressure. It refers to the pressure that remains in the airways at the end of respiratory cycle, and this pressure is greater than the atmospheric pressure. All right, and we have two types of PEEP. We have extrinsic PEEP and intrinsic PEEP. Intrinsic PEEP is what we know as the auto PEEP. So in extrinsic PEEP is that which you feed into the ventilator, all right, and it keeps your baseline airway pressure above atmospheric pressure. The idea is that PEEP helps to improve patients' oxygenation without increasing FiO2. Those of you who have worked with me, you know that I don't like high FiO2 All right. So a lot of times patients that have, hypoxia or SpO2 is dropping and the PaO2 on your ABG is low, the first thing a lot of people do is to just increase FiO2. Don't do that. All right. Don't do that because high FiO2 for a long time has deleterious effects on your patient. All right. Can actually increase their morbidity and mortality. There are adjuvants that you can employ, and one of them is PEEP. Okay, so PEEP of 5 is physiological PEEP because it is the same, pressure you generate with your closed glottis. So when we're talking about therapeutic PEEP, we're talking about PEEP above 5 centimeters of water, all right, which ranges between 10 to 30 cm. PEEP can actually go as high as possible, especially in refractory hypoxemia secondary to severe ARDS. So the first thing to do is not to increase FiO2 when your patient or if your patient is desaturating or you have hypoxia, especially in the ICU. All right, this may differ in the operating room because you are using the FiO2 for a short period of time. All right, and some of the anesthetic machines may not have some of these adjuvants. But for mechanically ventilated patients in the ICU, there are adjuvants that we can use to improve either your oxygenation or ventilation. Benefits of PEEP: it increases compliance by increasing the functional residual capacity. All right, it recruits collapsed lung. All right, opening up the alveoli. And this is important that we understand how PEEP works. All right, number one is that it increases oxygenation. All right, how does it increase oxygenation? You remember Henry's law. All right, the Henry's law of solubility. All right, the solubility of a gas in a liquid increases when the partial pressure of that gas increases in solution. So by increasing the amount of oxygen in the pulmonary circulation, it increases the solubility, and that's how oxygenation is improved in ARDS. Also, PEEP can also improve your VQ mismatch, by causing, opening the airway so that we have more airway, all right, for oxygenate. I mean, for what's it called? For vacuum matching, okay, for ventilation. The airway is open, then pulmonary blood flow is open. So it helps to improve the vacuum mismatch in this patient. And number three is that it also reduces work of breathing, especially in patients with fibrosed lungs. All right, because at the end of the day, the airways are open and it helps with exhalation. Disadvantages of PEEP are many. It increases dead space, it can cause barotrauma, and reduces cardiac output because of increased intrathoracic pressure. It can lead to oliguria, and some patients may be anuric due to renal hyperperfusion secondary to reduced cardiac output. And it's been seen that vasopressin secretion is increased with the possibility of increasing intracranial pressure. So it's important. And when you're using PEEP, you should be able to detect when there is intrinsic PEEP or auto PEEP. And we mentioned some of these things last week when somebody was asking me about how to suspect auto PEEP. I hope we still remember that. So PEEP is the first adjuvant in the armamentarium to improve oxygenation and ventilation in the ICU. The H there is what we know as the high frequency ventilation. All right, there are different modalities of high frequency ventilation, but the idea is you deliver low tidal volume as low as 1 to 3 mil per kg, all right, at a very rapid rate. All right, the ventilatory rate may be as high as 60 to 180 beats. Sometimes, especially in high frequency oscillatory ventilation, you can have a respiratory rate ranging between 300 to 900 cycles per minute. All right, so high frequency ventilation, you need to look at it in your ventilator whether this facility, all right, is available. All right, so indications of high frequency ventilation includes hypoxemia, that is refractory, all right, especially in ARDS, failure of conventional mechanical ventilation, and that's why I call it adjuvant. Okay, failure of conventional mechanical ventilation, failure to keep the lungs open, especially in instances of bronchopulmonary fistula, patients with pneumothorax, and above all, because you have reduced tidal volume, it helps to prevent ventilator-induced lung injury. Like I mentioned, there are 4 types of high-frequency ventilation. The most common one that we use is the high-frequency oscillatory ventilation. All right, what it does is that it increases, all right, the number of time that the blood circulates, oxygen circulates in the blood, and it improves oxygenation. The tidal volume is usually below the dead space ventilation, but it's compensated for with very high respiratory rate ranging between 300 to 900. All right, high frequency positive pressure ventilation. This technique is obsolete and is rarely used, but here it develops. It is delivered using conventional ventilator, where you set the respiratory at the maximum limit for the patient. High frequency jet ventilation is usually employed in units where you deliver a gas jet via a 14 to 16 G cannula inserted into the endotracheal tube, and you increase the respiratory rate to as high as about 100 to 150 per minute, and especially in patients with ARDS in infants. Or high frequency percussive ventilation combines high frequency ventilation and conventional ventilation. And most of the times in our common ventilator, you will find this mode, this technique, high frequency percussive ventilation. All right, so the next adjuvant is what we call the inverse ratio ventilation. All right, this technique reverses the typical IE ratio. We know that normal IE ratio is between 1 to 2. Expiration is usually longer than inspiration. But in inverse ratio ventilation, you want to increase the mean airway pressure and the inspiratory time. All right. So in inverse ratio ventilation, you can normally I just do 1:1. All right. Increase inspiratory time, and in severe ARDS and other causes of refractory hypoxemia, you can actually go very high. All right. People have used IE ratio of 4:1, but you need to be on the lookout because you have increased respiratory time, you're decreasing respiratory time, so you can have some carbon dioxide accumulation. But in cases that what your primary goal is to improve oxygenation, some permissive hypercapnia of PaC2 of 50, 55 may be tolerable for your patient, but it's not a technique that you use for too long. All right. Normally, when I do inverse ratio ventilation, within 2 hours to 4 hours, I will obtain an ABG to see if I have improved, my oxygenation. And it is also very important that you combine your adjuvants. So you're not just going to use only one technique. So what I do, I increase PEEP. All right, I try to do inverse ratio ventilation. And those are the 2 common techniques available in most of our common ventilators. So you may not need to increase your IE ratio as high as 4:1 because you're also increasing PEEP. All right, and don't forget also when you're increasing PEEP, you need to also monitor your mean arterial pressure so that you don't have hypotension. So by combining different techniques of adjuvants, you are able to achieve better oxygenation status. All right, indications is just like for PEEP, all right, refractory hypoxemia, all right, that is refractory to other ventilatory strategies. It's usually a rescue strategy, like I mentioned. It's not something you're going to use for 24 hours, 48 hours. All right, is a rescue strategy. And once you are able to reverse the hypoxemia, you want to quickly go back to I ratio as close to normal as possible. 1:1 may be tolerated for 24 hours, 48 hours, but going to 4:1 may have some untoward effect. So it is used as a rescue strategy. All right, how does it improve oxygenation? It reduces intrapulmonary shunting. All right, intrapulmonary shunting greater than 25%. All right, is severe hypoxemia. What does intrapulmonary shunting mean? It refers to the part of the alveoli that is well perfused but not well ventilated. So with IE ratio, inverse ratio ventilation, you are increasing inspiratory time, so you are increasing the ventilatory period, and you are improving your VQ mismatch. It decreases dead space ventilation because you're having limited time for expiration, increases mean airway pressure, but in cases especially patients with auto-PEEP, it helps, all right, in this regard. Okay, prone ventilation, all right. Prone ventilation is another way, all right, as an adjuvant to improve ventilation and oxygenation, all right. So, but you must realize that prone ventilation requires very deep sedation, RASC of around -4, all right, and sometimes you may be required to paralyze this patient. You need to do regular EBG to assess any improvement in oxygenation. And don't forget that there are lots of pressure areas when you put your patient prone. Some of the challenges is the availability of equipment in terms of bed. Turning the patient prone, there are mechanical devices on the bed that can do that, but when we need to do it with ourselves, we require an adequate number of people. Ensure that your lines, your tubes, your catheter, and all that are protected, and you need to protect the pressure areas. So these are the issues that are of concerns in initiating prone ventilation. But remember that prone ventilation is indicated when you are needing to have a PEEP greater than 7. I know that sometimes we have used PEEP of 10 and thereabouts, in our settings, but when you require higher PEEP in order to improve oxygenation, that's an indication for you to prone your patient. All right, patients with acute lung injury. All right, patients when the PF ratio, all right, is less than 200. Maybe a lot of times we have patients with 150, 180. Early onset. Proning has been shown to improve oxygenation in early onset, that is, LDS developing less than 48 hours after ICU admission. Efficacy is kind of conjectural and controversial in ARDS developing much more later than 48 hours. So proning is another way to do that. Inhaled nitric oxide. This was used especially in neonates, to reverse, what's it called now? What's it called? Hypertension. What is it called now? Intrapulmonary hypertension. Yes, because it has vasodilatory property. But its use has been extended to adult patients with hypoxic respiratory failure, and it improves oxygenation by reducing intrapulmonary shunting. All right, how does it do that? It increases blood flow, all right, to well ventilated lung area. Don't forget that there's what we have, this mechanism of hypoxic vasoconstriction. So in areas where there's a pause here, there's vasoconstriction, and the blood flow to that part of the lung is compromised. endangering and furthering causing severe hypoxia. All right, but with inhaled nitric oxide, all right, it causes vasodilatation of the pulmonary vessels, improves blood flow to those ventilated areas, and it helps improve oxygenation. The difference between inhaled nitric oxide and systemically administered vasodilators is that IV vasodilators will cause vasodilatation of all blood vessels, but inhaled nitric oxide is specific, is local, its effect is on the pulmonary vessels and improve oxygenation. Know that almost about 70% of all inhaled nitric oxide is excreted within 48 hours as nitrate in urine. You want to start as low as 1 to 2 per million, all right, parts per million, all right. So that is how it is given, 1 to 2 parts per million, all right, inhaled, and you gradually increase until you have your desired effect. I have not used inhaled nitric oxide, but for academic purpose, it is available. But just for you to know that it also is an adjuvant to improving oxygenation in your patient. The last adjuvant we're looking at is ECMO. All right, This is an artificial circuit, external circuit, just like your heart-lung machine. But what it does is that it carries venous blood from the patient and to a gas exchanging device where the blood is fully oxygenated and the carbon dioxide removed. The oxygenated blood is then returned back to the patient, all right, via a central vessel. Just like all the adjuvants, these are rescue modalities, all right. It serves to bridge recovery time, all right, before a decision is made as to the need for transplant of major organs. All right, just for your consumption, it has basic components. There's a blood pump, all right, which can be a roller pump, impeller, or centrifugal pump, just like your heart machine. It has a membrane oxygenator, heat exchanger, a controller, and you need to cannulate. All right, the tubings could be or could not be heparinized, but ECMO it has served as a bridging device to improve oxygenation while we're looking at more definitive modality of therapy. So that is adjuvant to mechanical ventilation. The R is the release or weaning of ventilator. All right, we said before that the moment you put your patient on ventilator, that is the time you want to start weaning the patient off ventilator. All right, so wean early is what we advocate, especially for patients requiring mechanical ventilatory support. So weaning off the mechanical ventilator is a gradual withdrawal of machine support, allowing the patient to resume spontaneous breathing on their own. All right, in all the units I've worked, I've tried to introduce these mnemonics. It's known as ghost criteria. All right, a lot of times when we want to start weaning an heart is when the patient is no longer a ghost. All right, so what does that mean? G, you want to look at GCS. All right, improvement in gas-glaucoma score of greater than 10T/15. All right, patient is hemodynamically stable. You have MAP of greater than 65 millimeters of mercury, and the patient is no longer inotrope. If a patient is maintaining MAP of 65 and above on inotrope, this patient does not qualify for this. This patient must be weaned off inotrope or minimal, very minimal, doses of your vasopressor inotrope. You want to ensure that oxygen has improved with your ABG and SpO2 respiratory rate is less than 35 circles per minute, FO2 is less than 0.5, with SpO2 greater than 90, you have a PEEP that is less than 10, tidal volume is greater than 5 ml per kg, and vital capacity is greater than 10 ml per kg. All right, you want to ensure that your patient has adequate spontaneous breathing with intact reflexes, and you want to ensure that your patient no longer has fever, the temperature is below 37 0.5 degrees Celsius. So once you're able to do this simple, GOES criteria, we're doing a study to validate it, all right? Well, this is what I've used for years, but we're trying to do some studies, a multi-center study. Please, if you're interested, let me know, chat me up so that I can send you the proposal, so that we can do a multi-center and validate this. But it has really been helpful in determining readiness to wean a patient off the ventilator. All right, there are other weaning predictive tests. All right, we have the spontaneous breathing trial, which is we're going to be discussing. Pray we have time at the end of this. Is one of our topics for today. All right, it's a validated predictive test. All right, for assessing the patient's readiness to be weaned from mechanical ventilation. Okay, we're trying to compare our GOES criteria with SBT and see if they are comparable and if they can be used. So what you do during your spontaneous breathing trial, you allow the patient to breathe spontaneously. Now, if you compare this with GOES criteria, your patient should have, passed the GOES criteria before you start spontaneous breathing trial. And that is the advantage of the GOES criteria we introduced. So your patient has passed the GOES criteria, and you allow the patient to breathe spontaneously either through a TPIS or you put the patient on CPAP mode. All right. Remember that CPAP also is not a standalone ventilatory mode. All right. Or you put the patient on low level pressure support, a pressure support of anything 5 and below. All right. And you do this for typically between 30 and 60 minutes. I don't like going up to 120 minutes because a lot of times the patient become very distressed with the increased work of breathing, and you may need to go back to full ventilation. So I do 30 to 60 minutes and assess the patient. All right. If the patient remains stable throughout the trial, you may want to consider them for extubation. Okay. Now, failure of your SBT is when there are signs of distress such as tachypnea, patient is desaturating, there are irregular heartbeats, patient is hemodynamically unstable. You need to abort your spontaneous breathing trial and revert to mechanical ventilation. But if the patient, like I mentioned, has passed your GOES criteria, GCS is greater than 10T, patient is hemodynamically stable, and and all that, you want to see that this patient is ready for spontaneous breathing trial. There are other weaning predictive tests like the Tobin's index. All right, Tobin's index is also known as rapid shallow breathing index. All right, this was gotten from a study that was published in New England Journal of Medicine as far back as 1991. All right, the Tobin's index is an objective predictive test as it calculates the ratio of respiratory rate, that's your frequency, to your tidal volume, and tidal volume should be in liters. So commonly accepted RSB, rapid shallow breathing index, is less than 100 or 105 beats per minute per liter. Now, when you calculate it, sometimes your ventilator does it, all right, or you can use a handheld spirometer to calculate your respiratory rate. Okay, so when your rapid shallow breathing index is less than 105, it suggests a higher likelihood of successful weaning. But anything greater than that indicates a higher risk of failure. All right, although it's not an absolute indication. Sometimes when I'm convinced that this patient can be weaned off ventilator and my calculated Tobin's index is more than 105, one of the common causes of this is anxiety. What I do sometimes is just give this patient a little dose of midazolam. Patient calms down, and you calculate your ROSBI, and you see that it's less than 105 breaths per minute per liter. So the fact that your SBI is greater than 105 does not mean that you can't, try to win this patient up. It may be anxiety. Try to look for the cause, and if it's anxiety related, give some midazolam and recalculate your RSBI and continue your winning process. There are other predictive tests in the literature. There are many of them. The winning failure prediction score, all right? I like this wins now, all right? The reason why I like wins now is because it's related to the common causes, reversible causes of failure to win that we know as wins not. So there are two of them. You want to see, can I win now? So that's when you use your wins now. Wins now. But if you are having difficulty in winning, you want to, troubleshoot and find out that why am I not able to win? And that's why we use wins not. All right. So wins now score is an acronym that stands for W, work for breathing. You want to check the work for breathing of this patient, injection fraction, and all that. High win score suggests that a patient is likely ready for successful winning and extubation. But if your wins now score is low, all right, it's an indication for potential risk or challenges in winning. All right, so what is the process of winning? There are two types. There are two processes of winning. All right, when we talk about winning, we're talking about liberating the patient from ventilator. That's one part. The second part is extubation. All right, so if you liberate your patient from ventilator, for your winning to be successful, you should be able to successfully also extubate your patient. So the first thing we do is want to do from full control to SIMV. But a lot of times now we don't do full control. In ICU, we start with SIMV, all right, pressure support. So we'll do SIMV, and that's why winning actually starts from the very day you initiate mechanical ventilation. So you put the patient on SIMV pressure support mode, and this reduces the requirement for sedation during the process, therefore facilitating the process of winning. Now, if you're successful, you go from SIV to PSV to CPAP. All right. Now, this reduces the ventilatory breaks that the ventilator provides, but because there's continuous positive airway pressure during CPAP, each spontaneous breathing of the patient is supported, ensuring adequate ventilation. Now, the success of this step will determine the success, all right, of your winning process. Now, when your patient is on CPAP for at least 2 hours, and sometimes we let it go 4 hours, you want to evaluate your spontaneous breathing trial, your RSB, and if the patient passes, you disconnect the patient from ventilator, all right, and put the patient on TPs. And after the TPs, you are ready to extubate the patient, all right? So how to calculate your TOBIS index is what I've put here, all right? But a lot of times, most of our modern ventilators can actually calculate your RSBI, which is an indication of successful spontaneous breathing trial. All right, winning is not always successful at the first time. All right, so when failure to win is when a patient fails to pass your spontaneous breathing trial. All right, that's number one. It also means that the patient needed or needs to be reintubated within 48 hours following extubation or liberation from a mechanical ventilator. All right, so when you're having difficulty in winning your patient off ventilator, you want to look at the reversible causes. And that's where this mnemonic wins not come in. All right, what are the likely reversible causes? What we're talking about reversible causes is if I deal with this cause, then winning should be successful. And that's why you should know this reversible causes of failure to win. It's known as wins not. Is a patient wheezing? Wheezing is an indication of obstruction. A lot of times, by the time we start weaning, we bronchodilate the patient, put the patient on salbutamol and some steroids, all right? Salbutamol helps. So if there's wheezing, you want to bronchodilate your patient. Is there any evidence of left ventricular, disease, all right? You want to check. And some of the common causes electrolyte derangement, especially hypokalemia and hypomagnesemia. All right, you want to look at your electrolyte panel and ensure that your potassium and magnesium are within normal range. Like I mentioned, anxiety. I've seen patients who are so comfortable on ventilator that when you try to wean them off ventilator, they refuse to be weaned off because they've been comfortable. They're anxious that, hey, this ventilator has been helping me. Am I sure that I'll be able to breathe? So apart from pharmacological way of dealing with anxiety, we need to reassure the patient, talk with the patient, and every morning that you start your weaning process, you let the patient know, see, the only thing that is keeping you here is ventilator. We need you to breathe on your own so that we discharge you home. Reassuring and talking with the patient, involving family and relatives or caregivers of the patient helps to deal with anxiety. Nutritional insufficiency, which could be over or under nutrition. We have a case in our ICU. We have a success story. This patient has been with us for more than 4 months, and he would try to wean off ventilator. But when we became focused looking at his nutrition, we changed his nutrition, and within a week of dealing with nutritional insufficiency, this patient was successfully weaned off ventilator and discharged to the HDU. It's almost like a miracle. So nutritional insufficiency is one of the reversible causes of failure to wean from ventilator. Sepsis, especially ventilator-associated pneumonia. Pneumonia, ventilator, like I said, is a life-saving device, but prolonged endotracheal intubation and mechanical ventilation will predispose your patient to ventilator-associated pneumonia. You can have overwhelming sepsis, and that will also, make your patient difficult to wean. Opioids, prolonged opioid use. All right. And with the advent, we had a discussion on sedation. With the advent of alpha-2 agonists, despentomidine, clonidine, all right, and the use of other sedative medications, reliance on prolonged opioid use has really reduced. But prolonged opioid use is one of the reversible causes. You can reverse your opioid, all right, and especially in settings that you have them. Thyroid disease, it could be hyper or hyperthyroidism. Most of the times, hypothyroidism is a reversible cause of failure to wean. So if you are having difficulty in weaning your patient off ventilator, look at the thyroid function test, and you may just be shocked that you have hypothyroidism in your hand. And giving tyrosine and treating this thyroid disease may actually help to wean your patient off ventilator. So the patient is not ventilator dependent until you have ruled out the reversible causes of failure to wean. Let me say this: do not label your patient to be ventilator dependent until you have corrected all reversible causes. The same thing I talked to people about brain dead patient. Don't label any patient brain dead until you have corrected all the reversible causes of loss of consciousness or coma. All right, I've seen a lot of people, interacted with people, this patient is brain dead. But you look at the patient's file, there are so many reversible causes of coma that has not been dealt with. The same thing, do not label a patient to be brain dead until you have reversed or you have dealt with all the reversible causes of coma. Don't label a patient to be ventilator dependent until you have run through the reversible causes and you have dealt with them. All right, troubleshooting. This is very important. Anesthesia and critical care has been linked to aviation industry. In fact, the simulation we do in anesthesia and critical care, derives from the success of simulation in the aviation industry. All right, so it's not enough to put your patient on ventilator. You want to be able to troubleshoot when things do not go the way you want. All right, basically, a patient on ventilator needs to be assessed frequently and urgently. If there is a problem with the ventilator or the patient, you want to do a quick assessment. Does this patient require urgent resuscitation? How patient is the patient's airway? Is the patient airway still there? Is there adequate and bilateral chest movement? The patient level of oxygenation can easily be checked and hemodynamic status. Howbeit, in cases of hypoxia, a patient on ventilator is hypoxic. You want to assess what are the things you want to troubleshoot. Look at the mnemonics dope. Patient is on ventilator is working, but the patient is desaturating, PO2 is getting lower and lower. You want to, is the ETT displaced tube, either ETT or tracheostomy? You want to check, is there any obstruction? All right, thank God for for most of the tubes where we have, they are corrugated. Sometimes during water run, somebody can inadvertently stand on your tube or your circuit, all right, and can cause obstruction. All right, is the patient biting the tube? Is there any mucus plug? All right, have you ruled out pneumothorax? In pneumothorax, we don't only give you hypoxia, it will cause hemodynamic compromise, especially in tension pneumothorax. Has there been inadvertent esophageal intubation? I told you a story of a nurse who was doing nursing care and inadvertently extubated a patient, but instead of calling the doctor, what she did was to just put the tube back there, and the tube went into the esophagus. These are the ways you troubleshoot when you have a patient who is hypoxic on ventilator. Hemodynamic stability. Your patient is blood pressure is low and the patient is on ventilator. You want to look at it. What is causing this? Could it be a reduction in venous return that is exacerbated by your positive intrathoracic pressure, either from your PP, positive pressure ventilation, or increased PEEP? Are there any drug-induced vasodilatation that is taking place, or myocardial depression? Like I said, tension pneumothorax. You want to identify and correct the causes of the hemodynamic compromise. For instance, in case of tension pneumothorax, you want to put a chest tube, or even the chest tube. Before you do that, you can put your needle cannulation, decompression at the second intercostal space, mid-clavicular line, and you'll be able to just reverse the hemodynamic instability. All right, other ways to troubleshoot the patient, especially patients who have what they call colloquially patient who is fighting the ventilator. All right, but we call it patient ventilator asynchrony. All right, when the patient is breathing out of step with the ventilator, it can lead to poor ventilation and oxygenation if you do not detect it. So if there is a patient is fighting ventilator, is not synchronizing with the ventilator, you want to troubleshoot the ventilator. Is the mode that I'm giving this patient appropriate? All right. For instance, a patient who is spontaneously breathing and the patient is on controlled mandatory ventilation. All right, they can't work together because the ventilator breath and the patient's breath will be, out of step with each other. So you want to ensure that. All right. Sometimes the patient is unable to trigger the ventilator, or there is presence of auto PEEP. All these may lead to ventilator patient asynchrony, and it is during troubleshooting you'll be able to identify and correct the cause. We talked about desaturation, all right, hypoxia. Patient, cough leaks of the endotracheal tube or tracheostomy tube. This will produce abnormal sounds, all right. I always insist when we're doing a round, you should have your stethoscope, listen, all right. Get close to the patient. Circuit leaks can occur at any junction in the patient ventilator circuit. Anywhere there's connection, you must be able to run through it. And sometimes it could just be somebody, just open, a valve or something, so it's very important. Sometimes there could be total disconnection and the ventilator is just blowing air, it's not going to the patient. So typically leak checks are, just like your machine check, all right, in theater. Before you put a patient on ventilator, you want to ensure that it's leak proof. You looked at your circuit, you look at your ventilator circuit, you look at the patient, and there are no leaks. But it's not only reserved for initiation of ventilation. On a regular basis, we must check for leaks in our circuit. All right, ventilator alarms. This is very crucial. All right, alarms are there to warn us. All right, now, being in anesthesia and critical care for some time, I can almost tell, when I hear an alarm, something is happening. For instance, if you're in theater, you're supervising the theater, and from another suite, you can hear a high-pitched sound, all right, lasting about 2 seconds. It comes again, lasting about 2 seconds. You can almost say that is an oxygen failure alarm. All right, so there are, alarm limits that are set in ventilators. So when there is an alarm, do not think that this machine has started again. It's calling for your attention. Go to the patient bedside and troubleshoot. All right, is it a high airway pressure alarm? Is it a low or low tidal volume alarm? There are so many. High respiratory alarm, apneic alarm. It will show you on the ventilator. For instance, when we have the apneic alarm, this can be triggered by 3 factors: either the patient, endotracheal tube, or the ventilator. So if the patient is not breathing and the patient is on spontaneous mode or assist mode, all right, the patient will not trigger the ventilator because it has passed the apneic interval, and this will give alarm. So it's important for you to get close to the patient and troubleshoot your ventilator. All right, this is a schematic diagram of troubleshooting the ventilator. And like we've mentioned before, with your plateau pressure, you can also detect auto PEEP in your patient. All right, where your plateau pressure is greater than 30 centimeters of water. All right, it shows that there's something happening. There's residual positive airway pressure in the alveoli. All right, air leak. If your peak inspiratory pressure is low, you want to check, is there air leak or there's hyperventilation. All these are ways to troubleshoot your ventilator. All right, I have 2 minutes more. I just wanted to talk about patient ventilator asynchrony. All right, this is when there's a mismatch between demand of the patient and the supply of the ventilator. It's pretty common in the ICU with an incidence ranging between 10 to 85%. All right, and this may be related to either the patient or ventilator or both. The most common patient ventilator asynchrony types are those that are related to triggering, all right, such as ineffective effort. The patient is not, for instance, the patient is not generating enough flow, gas flow to trigger the ventilator, or there's auto triggering, the ventilator is doing its own, or double triggering. All right, so delayed or premature cycling. All right, so you set your I ratio to 1 to 2, but the patient or the ventilator cycles before the end of inspiration or before the end of expiration. All right, these are all causes of patient ventilator asynchrony. All right, if one of these days we'll talk about ventilator graphs and waveforms. All right, those are very important sessions, especially that has to do with troubleshooting. One of the ways to promptly identify patient ventilator asynchrony is by looking at the ventilator waveforms. And all the ventilators will display waveforms for you, and you're able to see. For instance, in auto PEEP, if you're looking at the pressure time, the scalar waveform, you'll see that in presence of auto PEEP, the volume, sorry, the volume curve, volume time curve, the curve will not return to baseline, and you know that there's a presence of auto-PEEP. So it's important for us to familiarize ourselves with these waveforms. All right, so because of time, you have the slide, you can read it later on. So how do you manage auto-PEEP? I mean, patient ventilator asynchrony. All right, it could be clinical, all right, and you could also have some specific ventilator strategies. So when you have asynchrony, patient ventilator asynchrony, you want to control patient's pain, anxiety, fever, and agitation, all right? But no,
Anoluwa, please come, I need you here.
okay. So, but you know, a lot of times when patients have, when we have patient ventilator asynchrony, what a lot of us do is we increase sedation or we paralyze the patient. That won't solve the problem. That won't solve the problem. It will actually cause more harm. So when you have a patient ventilator asynchrony, avoid deepening sedation, avoid paralyzing the patient. There are a lot of things. Look at the pain, look at the anxiety, look at other causes. All right. Then the specific, if you have these different modes, proportional assist ventilation and the neurally adjusted ventilator assist mode, these are the best ventilator strategies to manage patient ventilator asynchrony. Okay, initiating the ventilation. Remember that before you put a patient on ventilator, the indication for mechanical ventilation must be reversible. Otherwise, you have a patient who becomes dependent on your ventilator. All right, obtain consent from relatives, or if the patient is conscious, you're hyperventilating, your respiratory rate is close to 40, you're going to tire out, we need to assist you. And if the patient is not conscious, you need to talk with the relatives because it's a form of therapy, it's an intervention. Always obtain an ABG before initiating mechanical ventilation. I put it in bold form, always. Now somebody will ask me, what if I don't have ABG? Well, tell your what's it called? You know, your policymakers that we can't ventilate the patient here without ABG. Let them know, because for medical legal reason, it must be documented that you are aware that you should have obtained a baseline ABG, but it's not available, and the management is aware of it. All right, because baseline ABG helps you to determine your smart ventilation, the setting, the mode, what adjuvants you're going to use, and all that. So obtaining an ABG is important. Ensure there's adequate supply of oxygen and proper working of the ventilator. There is nothing worse than trying to help a patient and improper function or inadequate supply of oxygen kills the patient while you're trying to put the patient on ventilator. Select your mode, like we mentioned before. Initiate your smart ventilation. Select initially FiO2 of 1, then reduce gradually until you are able to get an adequate PaO2 or SpO2 at the lowest FiO2. That's where you should keep it. All right, except you want to do therapeutic PEEP, you want to keep your PEEP at 5. That's physiological PEEP, except maybe in cases of asthma or COPD where you want to use lower level of PEEP. You know, in ARDS you can use 6 to 8 ml per kg for tidal volume. For other patients, 7 to 8 is okay. Inspiratory pressure, frequency, your pressure support, your assist spontaneous breathing, pressure, IE ratio, flow trigger is usually between 2 liters per minute, and you want to do your pressure trigger between -1 to -3 centimeters of water. All right, I think we should stop here. I've talked about spontaneous breathing trial, all right, and I just want to elucidate more on it. But let me quickly talk about the the SBT bundles, and then we would close. What's the time now? Yes, exactly 1 hour. Okay, so the spontaneous breathing trial, bundles, all right? Remember what a bundle is? It's something, a collective evidence-based practices that are done collectively to improve patient outcome. All right, so SBT bundle, the aim is to win within 48 hours. You want to win a patient off ventilator within 24 hours of fulfilling the required criteria. All right, what it does is that you want to prevent premature weaning and you want to also delayed weaning. So you follow the spontaneous breathing trial bundle. All right, so it can be connected while the patient is still connected to the ventilator circuit. Or TPs, you want to use a pressure support of between 5 to 7 centimeters of water. When I'm doing spontaneous breathing trial, I reduce PSV, your pressure support, to about 5. All right, and you want to reduce your PEEP. Okay, so we're trying to put the patient on minimal ventilator setting, all right, while you are supporting the patient to overcome the work of breathing through the circuit. All right, if the patient is on ventilator, like I said, put the patient on minimal setting. Initial trial shouldn't be more than 1 hour. I recommend, although the book say 120, but I recommend 30 minutes to 1 hour. Now, if after 1 hour you are not sure, it's not clear, it's equivocal whether your patient has passed spontaneous breathing trial or not, consider it as a failure. Put your patient back on ventilator. Remember, the shorter the intubation time, the shorter the spontaneous breathing trial required. When do you stop? When the patient is becoming tachypnic, hyperventilated, respiratory of greater than 38 for 5 minutes or less than 6 beats per minute, you want to stop. All right. When the SpO2 is getting less than 92, your adult patient is unable to maintain a tidal volume of greater than 300, heart rate, patient becoming tachypnic, blood pressure is dropping, patient becoming agitated, and all that. These are indications that you should stop your spontaneous breathing trial and put the patient back on ventilator. All right, we mentioned this last week. I think I should stop here and allow for questions and discussions. Yeah, so the floor is open. Let me stop recording so that